first speaker is Vedran Stefanovic. He's a senior consultant and professor of obstetrics and gynecology in fetal medicine in Helsinki University Hospital and Medical Faculty, University of Helsinki. Also, he has been visiting professor in the University of Split, Croatia, responsible for national implementation of cell-free DNA in fetal medicine in Finland, in public health care, and he's now senior lecturer at Medical School, University of Helsinki, Finland, with a wide experience in prenatal diagnosis and invasive procedure. He's presenting on the importance of cell-free DNA, pre-test counseling, and an overview on 3 years of implementation experience in a teaching university hospital. So, Dr. Stefanovic, you can start as you wish.
Thank you very much. Good morning, Mr. Chairman, and ladies and gentlemen, dear colleagues and friends. We have heard yesterday beautiful presentations, and maybe I will have it from a different point of view because I'm a clinician and a specialist for fetal medicine. And I'm going to present you the implementation of 3 years experience of NIPT because Finland is a social country. We have maternal care completely free of charge, and NIPT for high-risk patients are completely free of charge. And uptake of the first trimester, at least in Helsinki and capital area, is almost 95%. So that is kind of ideal milieu for doing this. I was asked to, like all the other presenters, to present my disclosures. I have nothing to declare except if I had a coffee from Illumina, I had a pen from Natera, and I have a chocolate bar from Ariosa. So, as you know, NIPT is a kind of a jungle today, and usually you say if you want to know about the trisomy 21, we should take just a few drops of blood, and we are going to let you know in a week or so whether you have baby with Down syndrome or not. Of course, it's not a counseling. So, sometimes I call it Mama Chat, to see what the patients are talking about, because we are a little bit so far away and we actually don't know, what they want. So I'm so sorry I couldn't put this in a more visible way, but this lady said she goes with her husband, and she said a hubby, is it husband in English, so, to do some Christmas shopping, have some lunch, because she's outside of London somewhere, and then she wants to know as far in advance of any issue. So she thinks that NIPT is any issue. And another one said, well, my husband said that it's not worthy. First, in first 2 hour pregnancies, they did not manage to get my Newhall translucency, so the quality of the screening is really questionable. And well, we can go on the second trimester screening, and if the risk is more than 1 to 50, then we can tip NIPT, yes. So we really don't know what they know, and they obviously don't know so much. I like the nomenclature, I like the languages, so actually I don't like even this name NIPT, non-invasive prenatal testing, because the first trimester screening with combined ultrasound and markers, it is also NIPT, so it doesn't make any difference. Of course it is better, but it is also NIPT. When we say cffDNA, it's cell-free fetal DNA, but I would say cell-free almost fetal DNA, because we know that the placenta genome is almost the same, but not the same. Talking about the NIPD, non-invasive prenatal diagnosis, which is in high-income countries used now for determination of fetal rhesus status, it's not also completely accurate and completely that specificity and sensitivity is 100%. So with the screening in 28 weeks of the ladies who are rhesus negative for their fetuses, whether they are positive or not, we are going to miss some, and we are going also to give immunoglobulin without a reason for babies who are actually rhesus negative, though NIPT says they are rhesus positive. So one has to know all the things about this when counseling the patients. When we started implementation in 2015 in our teaching hospital, I was asked to give an interview to a few newspapers, because it was quite a big hit in Finnish. So as far as there are a few of you that do not understand Finnish, so in this first one, look at this, they say this new NIPT method enables detection of the common, it's not screening, it's detection of the abnormalities, and it is instead of the amniocentesis. And in the next one, they said NIPT replaces risky amniocentesis, and our hospital has introduced a new screening method. So I gave them, to both of them, Angry Bird mark, and Angry Birds are from Finland, as you know. And in the medical journals, in the Finnish doctors' medical journals, this is me and my colleague midwife, of course, they were very reliable and good informations. I heard them many times yesterday, and people usually ask, moms ask, how good is this test, how accurate this test is? I will try to compare with this. Or, not in Helsinki, you can ask in Barcelona, how accurate is Barcelona metro? It usually means, does it come on time? But the test or metro can have all other things and other features. It can be fast, it can be clean, amusing, comfortable, expensive, cheap, or whatever. And metro is plane A for my trip from home to the hospital. I can go by bus or I can take my bike. So you have to discuss all these possibilities about the screening and in this comparison about how to get to your working place. When you see the word accurate, I'm not English speaker, native English speaker as you see, but when you put in Google what are the synonyms of the accurate, so you have specific, scientific, authentic, correct, proper, rigorous, and so all kind of things. So you have to deal with these and to tell patients what is PPV, what is negative predictive value, what is specificity and sensitivity, and it doesn't go within 7 to 12 minutes, which I heard that it is the main consulting time and counseling time in the United States in certain areas. Who should give a NIPT screening? Well, it depends, is it a first-tier screening or the second-tier screening? In our hospital in country where it is second-tier screening, actually it is the same, and most of our counselings are done by certified and well-educated midwives who are doing otherwise a job at a field medical center. Sometimes they are done by geneticists and in some occasions by fetal medicine specialists. So there are many counseling challenges. We don't go through all of these, but we know that the marketing has increased patient awareness of the availability of genetical testing, but unfortunately it has done much less to educate providers about when and how and where such tests would be appropriate. There are also some adverse outcomes included in this. It's mismanagement, because unfortunately many of the pregnancies are still terminated according to the only NIPT results without confirmation by amniocentesis or CVS. There is a loss of trust in medical providers. There are unnecessary use of healthcare resources, and obviously there are so much of inadequate counseling. So I have heard that in Netherlands, I hope there is someone from Netherlands, they are going to introduce, or at least they have already introduced, universal NIPT screening for all ladies in the country that has uptake of the first trimester screening of only 20%. So you will probably, if you choose NIPT, you will have a normal, and then you appear suddenly in 18 weeks genetic sonogram or 20 weeks with anencephaly. So whether it's worth it or not, I don't know, but we can discuss. I hope we will have some time. So what is known? The new data are emerging very fastly, and now I found out in White Journal the updated analysis of Gill, meta-analysis, that said that NIPT should detect and will detect more than 99% of fetuses with trisomy 21, 98% of trisomy 18, and 99% of trisomy 13, which is a little bit improvement compared to like 5 years ago. The false positive rate is about 0.13. But the number of cases, of reported cases for sex chromosome abnormalities, was too small for accurate assessments of performance of this kind of screening. Of course, as we said, the genome of the placenta is different from the fetus in certain cases, and there can be discordant NIPT positive results, and confined placental mosaicism is present in 1 to 2% of all pregnancies. For 21, it's not so big problem, it's only 2%, but for trisomy 13, it is present in 22 cases, for monosomy X, in 59%, and for trisomy 18 in 4%. So Professor Yaron Yuval was one of the co-authors of this great publication, which was actually dedicated to the clinicians and the people doing basic NIPT counseling, and it was in White Journal in 2014. But instead of this title, I would suggest they say what women may want to know. I would say what pregnant women should know about NIPT. So there are so many things, we don't go through all of them, but everyone who is counseling those ladies should discuss about what are trisomies 21, 18 and 13, what are the risks of these anomalies in general, what are the a priori risk of trisomy in this patient, and of course in the cases of fetal trisomy, as a post-test counseling, we should advise them, because we can't know, well, most of them of 18 trisomies or 13 trisomies are going to die in utero. It's not true, because not all of them are going to die. And as you see here, 48% of trisomy 18 and 46% of cases in trisomy 13, infants survive following birth for a median of 1 and 5 days and 7 days. So there are so many things that you should prepare that lady. Although it is not diagnostic procedure, sometimes in the patients who do not want to terminate pregnancy and we find anomaly, we take NIPT in order to see whether there is trisomy 18 or 13. Why? Because I'm an obstetrician and I don't want to do any cesarean section unnecessary for fetal indication. So though it is not so diagnostic, so usually they have kind of anomalies that we will find out in the second trimester. So we try to be very pragmatic. The second thing, okay, now I have an IPT normal, which is not proof that the baby is normal in that sense, but it is almost. So is this baby healthy? They ask, is this baby healthy? The health is something else than the normal karyotype. We know that 3% of live-born children have major congenital anomaly, and when we exclude trisomies, no matter what way, NIPT or diagnostic test, we just lower the risk for anomalies from 30 per 1,000 to 28 per 1,000. So there is so long way to the healthy baby. What are the chances of detecting of other fetal anomalies? In the first trimester, according to the certain publications, you can detect up to 47% of major malformations. So Howard maybe can later on comment on that. And in routine 20-week anatomy scan, you can detect 50 to 60 of all major anomalies. From what testing options can pregnant women choose? Of course, according to the local setting. That's a little bit weird that in Europe and in northern countries, like one is in Norway, if you know, you should know that Norway is one of the pioneers in the obstetric ultrasound, and it's completely forbidden by law to do the first trimester ultrasound screening and any kind of screening. So they fly to Sweden and they fly to Helsinki, to Finland for the test, and they're doing it. Who is going to counsel them? So that's a big problem. What are the chances of a failed test? Of course, for those, it completely depends, and it's very relevant in the countries where you have a certain limit of the pregnancy termination. In Finland, it's 24+0. In France, you can terminate whenever you want. So 1 day or 2 days, it just matters for some patients. And if you have no call, you have option for another blood test or for invasive procedure. Those no-calls rate are quite different in the literature. They vary from 1 to 5%, and in our sample you will see later on it is just 1.2. The more obese woman, the higher chance to get no-call result. And the result is available from 7 to 10. I hate when they put on the firm like it's 7 to 10 working days. Patient doesn't like any working day. You can have a holidays, 7 days, and it's working days. So it's 7 days or 10 days, but not any working days, because it's including weekends. How accurate? Patient, it's very, very difficult in that anxious state to understand all these odds ratios and the stuff, and one should provide in a maternal language, in the native language of the patients that they speak, these things which are very well known to you. We, as other countries in Western Europe have problems with migrants who are in certain cases of the lower educational level. The language is problem. You don't know whether this interpreter speaks exactly the same language, and when you try to cancel NIPT and then you find out according to the expression of the face of the patient, then you ask, can you ask her, does she know what is a chromosome? So the interpreter says, and she's, do you know what is Down syndrome? So it's just like this, and it's very, very difficult. We have to bear in mind, if this test is done in the 20-year-old woman as a first-tier screening, and she turns to be NIP positive, only 1 to 3 or only 1 to 4 will have really Down syndrome. So you have to make amniocentesis or CVS to 4 of them to detect 1. So patients don't understand then unless you tell them. And also, in some countries that they have a sex selection, which is of course not good, you have a problem that they can mail their sample to some other countries, and you should be aware that you are not doing some stuff that is actually illegal in some other countries. Determination of the sex by an IPT is also not 100% accurate. In the meta-analysis, which is quite a fresh one, on 10,000 samples and 90 studies, the sensitivity and specificity varied between 95 and 99%. Well, about the sex selection, I think we don't have time to talk about so much. How about sex chromosomes aneuploidy? Because Turner syndromes, it's really horrible. Even mother can be turned to be mosaic Turner or NIPT. It is very, very unreliable. The false positive rate of monosomy X was surprisingly high, according to the last report in the prenatal diagnosis. So even without hydrops or hygroma, one should definitely confirm the positive finding by invasive procedure. I skip this one. So Finland, Nordic country with less than 60,000 births annually. Maternal care is guaranteed by law, and you are obliged to offer all women first and second trimester screening. For in certain areas, the uptake is like 60% in the northern area in Finland, and in the southern area and the capital area is almost 95%. We have even completely free of charge maternal care and the screening even for asylum seekers. Maternal, neonatal, and infant mortality, also stillbirth rates, are amongst the lowest in the world. Mothers with the trisomy 21 fetuses continue pregnancies in certain Finnish areas. In 30 to 40% of cases, even they can still terminate the pregnancy, and in the capital city, it's about 10 to 20%. So you have to take care about this, to know this data, and to counsel it accordingly. And so there is no any rush if she says, I'm not going to terminate, but I just want to know with high accuracy, let's say, whether I have Down or not baby, and I can prepare for it. So the settings of different countries are completely different. So we were forced actually by the private sector, who started in 2013, and it is not reimbursable in the private sector. They have started in 2013, and they have been screening for all kinds of sex chromosome, for microdeletions, and when they turn to be positive, so they send them to us sometimes, and in most of the cases for counseling and for invasive procedures. But now our cooperation has really improved, and we don't have so many cases anymore. And then we started, it is not easy to implement, it's nationwide. We have, of course, been searching the literature, we have been learning, we have prepared the leaflets and all kinds of things, and also we have invited Howard to talk to us. We had the symposium, nationwide symposium, and then we started to implement it in Helsinki University Hospital, which covers the 4th of all births in Finland in 2015, and then all the other hospitals started very soon after that. First blood sample was drawn in January 2015, and as I told you, the other university hospitals followed. in every prenatal clinic, all the patients are given in the Finnish language, of course, and the Swedish, because we are bilingual. In certain cases in English, because there are quite many foreigners in the capital area. This is nothing special, like anywhere, but they want and they should know what are the options. And in the written material, in very details, what is specificity, sensitivity, what is detection rate of first trimester screening, what you do in the second trimester screening, what is amniocentesis, all these kind of things. They don't get information about NIPT unless they get caught as a risk group. So, just to skip this one and to show, so what is so far in our hospital and in most of Finland, how we do this? We didn't have enough money to provide it to all patients, only for the risk patients. And the risk patients now are the risk patients like they used to be 2 years ago. So we provide NIPT as an optional. You can decide NIPT or invasive if you are one of those patients in the first frame. FTS risk 1 to 11 to 1 to 250, which is our cutoff for invasive procedures. No ultrasonography up to 3.4. Mid-trimester screen positive, which is very rare nowadays in Finland. Maternal age over 40, but first trimester screening undone. You can't appear as a 43 years and say, I have a NIPT because I'm a high risk. You must have first trimester combined screening done and a common trisomy in previous pregnancy. So on the right side, you see those which are not offered NIPT. If you have no ultrasonography more than 3.5, any structural abnormality excluding soft markers, if you have a first trimester screening risk more than 1 to 10, and IUGR on the second trimester screening, because there's so many of these uncommon chromosomal abnormalities. What is very important, all these include really one-to-one person counseling, which we are going to stick to that. So to go back, overall NIPT uptake was in 2.5 years, 82%. No call results, only 1.2. And as you see, the uptake was almost constant, between 75 and 90, but the median was 81.6. Why? We expected even a higher uptake, but we can draw the samples only Mondays and Tuesdays because we send it through contractor in subcontractor in Belgium to the United States, and now we are trying to have it in. So this is a big problem, and you will see now in the evaluation of our patients, our publications, how it is quite a big problem, of course. So, not surprise, surprise, these are CVSs in red in 2014, before NIPT, and in blue are after NIPT. Amnios, red, before NIPT and after NIPT, and total invasive procedures, they have dropped up to more actually than 50%. The problem is, am I going to teach new residents doing this? So you can decide yourself for your own patients. So, what about our publications? We want to scratch the surface. We wanted to see, are they satisfied? What are the choices? Why they choose this or that? So in our first publication, we have 5 publications. 2 are published. 1 is in press, one is submitted, and 1 is in preparation. So I'm going to just briefly to introduce you to 3 of them. So we investigated in the first publication the factors influencing women's post-counseling choices between non-invasive prenatal testing and invasive prenatal diagnosis. The risk groups, you know them already from our flowchart, were those. And what we have found? We have found that when you take together all these women, no matter which kind of risk they had, 78% took NIPT, 18% choose CVS, and 3.3% choose amniocentesis. It's worthy to find out that before NIPT, after you got positive for screening, we had almost 10% of the ladies didn't want anything because they did not want invasive procedure. Now, after NIPT, we still have some of them that don't want anything. So no NIPT, no invasive, nothing, about 3%. So it's going a little bit better, but we have to respect the patient's choice, and we never say you should do this. We give just the options and the proper counseling, and your choice is your choice. The counseling day is very important, because if you come on Wednesday, you are less likely to take NIPT because you are available, you can do that, but you have to come again from 2 hours driving to Helsinki to Monday to do that. Multinomial logistic regression only confirmed the predictive value that of gestation age and counseling day of women's choice, and actually the age was not at all important in our screening. I mean, what are you going to choose? And it's very important to know, because we assume that 45-year-old woman always want invasive, just to be sure, for the only and the last child. In the second publication, which was published in PLOS, actually it was almost the same setting, but we just took only the high-risk patients that have been caught on the first trimester combined screening, because nuchal translucence is another thing, previous Down syndrome is another thing, so they have different attitudes. So what were the results? NIPT group had more advanced stage than in 2 invasive test groups. Women that have chosen NIPT were more likely to have counseling on Monday or Tuesday, again that Monday and Tuesday, and women choosing CVS had higher serum screening risk scores. Again, gestational age and counseling day were very strong factor influencing women's choice, and service availability and convenience are strong factors. Medical risk status in this choice context is not highly influential, in contrary to many other publications. This is a pilot study, and this is not published, and this is not submitted yet, and this is, but I just show you this one. We have proven with very convincing p-values that our women are very, very happy with the counseling, with the personal counseling, and what is very important, that their anxiety, even if they don't have yet a result, the blood test was just drawn, or you have amniocentesis, they don't have any idea what the results are going to be, the level of their anxiety after the counseling, before the results, it has not diminished, but actually it has diminished, but of course not completely went out. So, in summary, there is room for improvement in NIPT. NIPT should not be just another blood test more. Counseling should be not directional and driven by medical professionals, not the companies, and regular updating of knowledge is what we owe at least to our patients and their kids. And I would like to thank you and to invite you sometimes to Finland, which has 300,000 lakes, not thousands.